Thank you, Keith, and thank you so much for the invitation. It's really a pleasure to be here with you, and thank you to the audience for really staying this long. But the fetal imaging is really a wonderful topic, and I want to convince you in the next 20 minutes that placenta is also a fetal organ. So we're going to talk placental pathology and how these affect the fetal brain development. So what's the relationship between placental pathology and fetal brain? Actually, there is a growing body of evidence that links placenta pathology, placenta physiology, and brain development. And there is a new exciting field that has been coined as neuroplacentology that has emerged. And actually, placenta, as I just said, is a major fetal organ, and it receives a great amount of the fetal cardiac output. And actually, when there's a disease process that affects placenta, that's going to have a major impact in the overall fetal circulatory system, and specifically to the blood flow that's going to reach the fetal brain. And on the contrary, if we have a circulatory problem in the fetus, that can lead to placental damage. And that also can turn into further fetal organ dysfunction. We need to remember that during pregnancy, the vascular compartment is actually composed by three compartments. There's the maternal compartment, the placental compartment, and the fetal compartment that are each of them, there are all these structures within each of them. So it's a pretty complex vascular compartment. So what happens is that there are many different factors that are going to lead to placenta dysfunction. And these factors, they may include inflammation and infection, environmental factors, umbilical cord abnormalities, genetic mosaicism, maternal diseases, congenital heart disease, and many unknown factors that lead to placental dysfunction during pregnancy and eventually lead to perinatal brain injury and to long-term neurodisability. So we're going to start from the beginning, just to remember what's placenta. Placenta, as I just said, is a unique transitory fetal organ, but it has also maternal subtypes, not only fetal. So it consists of two components. The maternal component is called the decidua and is the inner portion and is formed by the trophoblastic invasion of the endometrium. And then we have the fetal component that is called the chorion frondosum that is formed by the arterial plexus. That means that there are branches from the umbilical artery that are going to protrude in the intervillous spaces as chorionic villi. And here we have a nice drawing representing all these. And here we can see the chorionic villi and the decidua. And the human placenta is what is called an hemochorial placenta. What does this mean? This means that there is a direct contact of the maternal blood and the chorionic epithelium is buried in this maternal blood. So placenta is not only an organ that is related to nutrient and gas exchange, as we all learn in medical school, but it also has a main role as an endocrine organ. It secretes many hormones that are really important to maintain pregnancy, to prepare mother to recognize the fetus, to prepare for delivery. And also, it protects the fetus from any immunological attack. And it also plays a role in neuroprotection and in the normal development of the fetal nervous system. How do we assess placenta by imaging? We've been assessing placenta by imaging since long ago with ultrasound and Doppler ultrasound. We know that we can recognize the chorion and the chorion frondosum since 10 weeks of gestation. By 12 weeks, we can recognize the intervillous flow. And by 18 weeks of gestation, we may recognize the retroplacental complex that is kind of hypoechoic. And we know that placenta is also a complex organ that is going to change through gestation. When it's very early in gestation, we have a grade 0 placenta, a placenta that is very uniform, very smooth. And if we go further into the gestation, placenta is going to get more heterogeneous. We may see by the end of the gestation some calcifications that are typically coma-like. And with late in gestation, we may have a very mature and calcified placenta. And we know since long ago that when we have a rapid progression from grade 0 to grade 3 placenta, that may represent an hypermature placenta and represent that there's some placenta serious pathology. And here there are some examples of normal placenta by 28 weeks that is very smooth and homogeneous, and some calcifications that are completely normal by 34 weeks. We can also assess this normal appearance of placenta in MRI, as it was nicely shown by Daniela Preyer in this paper. And as you may see, by the end of the gestation, the placenta gets more heterogeneous and thinner. We also need to assess not only the placenta anatomy, but we also need to assess the function, and that's much more tricky. And so far, we've been doing this by ultrasound. We do the Doppler ultrasound of different arteries and veins. Typically, the uterine arteries Doppler, the ductus venous Doppler, the umbilical artery Doppler. And we also calculate with the MCA Doppler in the fetal brain. And we calculate, the MFL specialists in Spain calculate the cerebroplacental ratio. That means that there's this ratio between the pulsatility Doppler index of the fetal middle cerebral artery and the umbilical artery. And when all these indices, they show pathology, they may represent a placental pathology. In MRI, in our protocol, we always get anatomical images through all the placenta, and also diffusion and T1. We have a specific protocol when there's a suspicion of abnormal placentation, but I'm not going to talk about that today. But you always need to look at the placenta and comment on the location, the thickness, or the volume if you think it's abnormal. If it calls your attention and you think it's too heterogeneous, you can mention that in the report. And of course, if there's something that may be dangerous, like a retroplacental hematoma, we need to look at the umbilical cord and try to check the cord in section, and also check if there are 3 normal vessels in the umbilical cord. Since the last 10 years, there's also an interest in developing sequences to assess placental function by MRI. So one that is pretty popular in the literature is the beam diffusion perfusion technique. We've been doing this for research purposes in our institution. And actually what you get this perfusion fraction map, and you can place an ROI in the maternal size and in the fetal size, and it will give you this F value, that is the perfusion fraction. And we know from the literature that the F values are able to distinguish the fetal growth restriction fetuses from normal pregnancy, so they are able to depict placental pathology. However, it's kind of tricky because there are gestational age-associated changes in placental E-beam, and there's also a lack of reproducibility and a lack of ground truth. What is really interesting, and maybe really interesting in the future, is that you can check fetal brain perfusion and placental perfusion at the same time in your study. So I think it's going to become more popular in the future. Another technique to check for placental normal function is the T2 mapping. And it has been also shown in the literature that you can see a different T2 star decay in the fetal growth restriction cases compared with controls. And even in some groups, they've been doing research doing a hyperoxy T2 star response. So let's move on and start talking about abnormal placenta and placental pathology. In 2016, there was a group of placental pathology experts that came together and tried to clarify a little bit the prenatal classification and the classification of placenta pathology. And they concluded that there are 4 major groups of placenta pathology phenotypes: the maternal vascular malperfusion, fetal vascular malperfusion, acute chorioamnionitis, and bilitis of unknown etiology. Each of one represents a different type of etiology and pathology, and we'll go through them. And what's really interesting in this study, that it was performed in Cleveland Clinic, and they studied the specimen of placenta from term, late preterm, early preterm, and previable pregnancies, and they saw that that fetal vascular malperfusion pattern was more common in term pregnancies, And the acute coronaritis was actually one of the patterns that was basically seen in early preterm deliveries. So it was a major cause of that. And maternal vascular malperfusion was the cause of early preterm, but also we could see that in term deliveries, and we'll go through that. So how does placenta mediate this mechanism of prenatal brain injury? So it can be due to a paucity of protection, as we said before, total asphyxia, partial prolonged intermittent asphyxia, chronic hypoxia, thromboinflammatory processes, reduced placental reserve, or what is called positive preconditioning. And I will show you a few cases from our institution that hopefully will illustrate these four placental phenotypes. This is case one. The mom was 30-year-old, and she was treated with a preterm labor and increased uterine contractions. It was a previously asymptomatic mom with a normal prenatal screening in lab and ultrasound, as she ended up delivering a 29 gestational age fetus. And this is the brain of the baby at term corrected age, and this is the ultrasound. So you can see that when we did the MRI at term corrected age, there was a pretty bad hypoxic ischemia with a pattern of cystic leukomalacia in the periventricular white matter. So what happened in the placenta in this case? So actually, this was a case of intramniotic infection. The maternal inflammatory response in the maternal side of the placenta was an acute coronaritis at stage 2. The fetal inflammatory response was also an stage 2 with infiltration of the umbilical cord. Why is important to look at the placenta in these cases? We know that acute coronaritis, that is called also intramniotic infection, is of an infectious etiology. So here we know that the cause of the preterm delivery is actually an infection. But moms are often asymptomatic. And it's very important to recognize this pattern, because when there's a high grade of fetal inflammatory response, is associated with adverse neurological outcomes. And that's something that we didn't know before. And these cases are, it's a very common pattern that is found in the early preterm delivery, as I said before. This is case 2. Case 2 is a 41-year-old mom with a severe preeclampsia, previous history of kidney transplantation and chronic hypertension. So this mom, she had a very pathological Dopplers at 25 weeks with absent diastolic flow in the umbilical artery. The brain placenta coefficient was also very low. That was a severe and early onset of a fetal growth restriction, type 1. And the estimated weight was very, very low. So it was a premature delivery at 25 plus 3 days. And if you look at the brain, it's actually, it looks at the succession is really delayed for 25 weeks. It looks more like 23 weeks. And when we look at the placenta, this was a cause of maternal vascular malperfusion. The placenta was very small for gestational age. There was a retrocordial hematoma. And here you could see that there were signs of atherosclerosis, placental infarction, and accelerated villus maturation, that these are all within the diagnostic criteria of maternal vascular malperfusion. And this baby did very bad, actually. This baby also developed an enterocolitis, necrotizing enterocolitis. Here you see the large pneumoperitoneum, very bad lung disease. And it also developed a severe hypoxic ischemic injury in the brain with this pattern of cystic leukomalacia, and eventually the baby passed. So maternal vascular malperfusion is something that we can suspect when there's a combination of preeclampsia and fetal growth restriction. But there are many other maternal factors that are risk factors for this condition. And we have that these babies are at risk of fetal growth restriction, but also preterm delivery, fetal demise. And if the baby survives, there is an increased risk for future cardiovascular disease in both the mother and the child. So again, this is an argument to do a placental study. Let's move on to case 3. This was a case of CMV and fetal growth restriction. And this patient, by the end of the pregnancy, also saw that there was a decreased pulsatility index in the MCA in the brain. The brain placenta coefficient was also abnormal, and there was a type 1 fetal growth restriction. We performed an MRI in this case, but not to look at the placenta. It was mainly to look at the fetal brain to see how if there was signs of, we've just seen this was a case with ventriculitis and white matter injury and subependymal cyst, but placenta didn't look that bad on MRI. And this is the postnatal MRI, and this baby had the white matter lesions and hearing loss, and also had the type 1 intrauterine growth restriction. The fetal birth weight was really low. So in this case, the pathologist could see that the placenta was very small for the gestational age, and there was a chronic bilitis and also hemosiderin deposition. And this is within the group of bilitis of unknown etiology, even though in this case we knew it was the CMV placentitis. So this group is actually secondary to a maternal T-cell mediated immune response to antigens in the fetal villus stroma. And it has been shown that the vast majority of the cases are of unknown etiology. That's why it's called like this. But in this case, it was a CMV infection. And why it's important, again, to look at the placenta, because we know that chronic bilitis and changes are higher in mothers with symptomatic infection. And also we know that the fetal body weight and the risk of fetal growth restriction in CMV is going to be also higher in placenta with CMV detection and bilitis. This is case 4. Case 4, I think, is really interesting. Actually, it was a case with a fetus that was diagnosed with this syndrome, with this Hutchinson syndrome that was secondary to an H2 mutation. The mom was referred to us at 28 weeks for short long bones, bone incurvation, bone mineralization, echogenic large kidney, and in the exome trio, this mutation was found. But this disease is actually not related to brain disease. It's only associated with non or very mild developmental delay. So at the end of the pregnancy, the placenta was really starting to become very, very abnormal, very echogenic in ultrasound, very, very heterogeneous on MRI. And the Doppler was, the uterine artery Doppler was really abnormal. And there was an emergency section because there was a loss of fetal well-being. And the baby, when the baby was born, he was encephalopathic with signs of moderate hypoxic ischemia. And in the AEG, it showed a refractory convulsive status. So we did not understand what was going on. The umbilical artery pH, as you see here, was not that bad, a bit low. On the MRI, we could see on day 1 that there was really signs of very severe brain involvement. So there was an abnormal white matter signal intensity, really widespread in the brain, abnormal signal intensity in the corpus callosum. The pons was small, also abnormal looking, and there was already abnormal signal intensity on T1 in the basal ganglia. So, and in the IDC map, we could see some periventricular ischemia. So actually, this was the case of a fetal vascular malperfusion, probably due to a cord occlusion. So there were occluded chorial vessels, a vascular villi, a thrombosis in the stem villi, so nothing to do with the genetic condition of this fetus. So it's strongly associated with chronic or partial intermittent umbilical cord occlusion. The risk factors are maternal diabetes, this antiphospholipid syndrome. So there are several risk factors, but when there's this fetal vascular malperfusion, the adverse outcomes that are associated is fetal demise, encephalopathy, fetal stroke, and cerebral palsy. And yes, I would like to mention at the end of the talk that there's a lot of work that is being done very recently on congenital heart disease, placenta, and actually pregnancies with fetal congenital heart disease, placental pathology is caused primarily by maternal vascular malperfusion. And when there's higher placental pathology, there's going to be a worse neurodevelopmental outcome for the baby. So it's very important to look at the placenta when we have cases of congenital heart disease. And there's this very nice paper that has been done by the CHD Lifespan Study Group. And the last disease I would like to mention is the confined placental mosaicism that occurs when there's an abnormal cell line that is confined within the placenta, but not in the fetus, and that can also be associated with fetal growth restriction and premature birth and pregnancy complications such as preeclampsia. So in conclusion, there are many placental-mediated mechanisms of prenatal brain injury. We reviewed the current use and limitation of MRI in assessing placenta function, but of course, there's a lot of work to do because monitoring placental health is going to be really important in the future, and targeting placenta pathology may hold promise as a prenatal intervention. And here, as fetal imagers, we have a lot of work to do. I would like to thank you all for your attention, but first I would like to thank my colleagues in Barcelona and especially the pathologists who really worked me through this complex topic. Thank you.